Hi there, my name is Emma. I'm a PharmD Candidate. This is Med Ed 101, and today we're going to be starting a series talking about potential clinical guideline updates. It'll be 3 short videos that are going to be sort of mini journal clubs, and the first one we're going to talk about is Fineronone in HF, or heart failure with preserved ejection fraction. So the objectives for this presentation, we're first going to go over some background material, so just to describe mineralocorticoid receptor effects on the body, describe why finerenone, so describe the differences between steroidal MRAs and non-steroidal MRAs, talk about a couple different background studies that led to this research, and then talk about the FINEARTS trial and cover the major findings and whether or not it'll change practice. So, mineralocorticoid receptors are distributed throughout the body. So within the blood vessels, they can cause endothelial dysfunction, oxidative stress, inflammation, fibrosis. Within the kidneys, renal inflammation, potassium excretion, they increase intravascular volume and blood pressure. Within the heart, they cause hypertrophy and remodeling. Within macrophages, they cause infiltration and pro-inflammatory mediators. And then within the large intestine, they can cause some sodium retention. So this graphic comes from a paper that talks about 4 different arguments for the use of finerenone, as well as the previous graphic. And I think this does a really good job of summarizing the differences between steroidal and non-steroidal MRAs. So you can see spironolactone and eplerenone are our steroidal, and then finerenone is our non-steroidal. Finerenone is unique in its structural properties in that it's bulky, so it has greater potency and selectivity at mineralocorticoid receptors. Spironolactone is also very potent at that receptor, but it's not very selective, which is why it has a lot of the side effects that it does, along with eplerenone. Versus finerenone, it doesn't have as many of those sexual side effects or increase in hyperkalemia. For metabolites, there is no active metabolite of finerenone. The half-life is about 2 to 3 hours. Another important factor is that tissue distribution is equal between the heart and the kidneys, which is unique to finerenone. Spironolactone and eplerenone, as you can see, the kidneys are much more favored in terms of distribution. In terms of CNS penetration, finerenone does not penetrate the CNS, which is good because then again, it doesn't have a lot of those side effects that spironolactone and eplerenone can have. It does not, however, lower blood pressure very well compared to the steroidal MRAs, again, due to that CNS penetration or lack thereof. And excretion is pretty similar across the 3 groups. So now we're going to jump into a couple of different background studies. So the first one is the ARTS trials, which is a group of trials looking at finerenone and type 2 diabetes, CKD, and heart failure with reduced ejection fraction. And this was a group of phase 2 trials. So what they found is that there was a dose-dependent reduction in albuminuria. There were similar side effect profiles between the comparator or placebo. Also, there was a similar rise in serum potassium levels versus spironolactone. And the anti-proteinuric effect can be maintained with limited effect on serum potassium, which is all great. And then the FIDELITY trials, so these are phase 3 trials. It's the Fidelio DKD and Figaro DKD, which are in that FIDELITY group. So these looked at finerenone in CKD and type 2 diabetes. So they found that it significantly improved long-term kidney and cardiovascular outcomes and albuminuria versus placebo. The rates of hyperkalemia were increased in the finerenone group, but discontinuation of the finerenone group was low. So while there was some incidence of hyperkalemia, it wasn't at a rate that was very high or increased enough to a point where they needed to discontinue the drug. And then the composite endpoints, so composite cardiovascular outcomes, which included cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization from heart failure, and kidney outcomes, which included kidney failure, sustained or 57% decrease in eGFR over 4 weeks, or renal death, both of those outcomes were significantly reduced in these trials. So now we will cover the FINEARTS heart failure trial. So that's looking at finerenone and HF, preserved ejection fraction, and mildly reduced ejection fraction. This study was published on September 1st of 2024, so quite recently. The main objective of this study was to examine the efficacy and safety of finerenone in patients with heart failure with mildly reduced or preserved ejection fraction. So, the trial included patients who were 40 years or older, they had symptomatic heart failure, and they had mildly reduced or preserved ejection fraction. This trial was event-driven, double-blinded, randomized, controlled, and an international trial, which included 37 different countries. Finerenone was used at either 20 milligrams or 40 milligrams once daily and compared to placebo in addition to usual therapy. And the primary outcome was composite total worsening heart failure events and death from cardiovascular causes. And you can see here the number of patients in each of the groups was around 3,000. So, the major results from this study. So finerenone use resulted in significantly lower rates of total worsening heart failure events and death from cardiovascular causes. So worsening heart failure events were defined as first or recurrent unplanned hospitalization or urgent visit for heart failure. The rate of worsening heart failure events was also lower in the finerenone group, and finerenone was associated with an increased risk of hyperkalemia, but decreased risk of hypokalemia. Also to note, there was no improvement in the NYHA class, functional class, if you're familiar with those, but there was improvement in the functional assessment score that they used, which was KCCQ. And then discontinuation rates were similar between the two groups at about 20%. So hyperkalemia didn't necessarily seem to have created an increased risk of discontinuation. So how has practice changed? So UpToDate now provides finerenone as a potential option for MRA use in heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction. Although guidelines have not been updated yet to reflect this change, future guidelines will likely mention this. Currently, there's no recommendation for one MRA over another, as they're seen to be equally efficacious in heart failure. So there are likely updates coming to guidelines, but they haven't been reflected yet. Here are the references I've used for this presentation. And thank you so much for listening. If you have any questions or comments, please drop them down in the comments below. And thank you for your time.